is such a pleasure to be here today with my good friend and a longstanding colleague, Salim Virani. We were just treated here at the American Heart Association Epidemiology Conference to a fantastic lecture, really describing the global challenges and opportunities related to cardiovascular disease prevention and management. I take up the whole time describing all of Salim's accolades, so I'll just be brief by saying he's currently the Vice Provost of Research at Aga Khan University, where he actually got his medical training initially. He's also an endowed professor there, and he's really doing global collaborations around research and science in this field. Prior to that, he was at Baylor College of Medicine, where he was a tenured professor as well as the director of the fellowship program. And many of us through the American Heart Association, I've had the great pleasure of collaborating with Salim for many years, but I've known him through many, many different initiatives. He was the chair of the Chronic Coronary Disease Guidelines. He was the chair of the Statistics Committee and the statistics report that comes out annually. And then we also had the pleasure of collaborating on both the 2018 cholesterol guidelines as well as the Cardiovascular Kidney Metabolic Health Initiative. Salim, it's just an honor to have you here with us today.
Same here, Chiadi. Always a pleasure to be a volunteer for the Heart Association. Always a pleasure to be working with you.
Well, thank you so much, Salim. Well, your talk gave us quite a bit to think about, and it seems like the story is not simple. There's a lot of different kind of contours and elements to the story. So the first thing that I really took from your talk was that some things are actually getting better. There's some things to be a little bit excited about, while at the same time, some other things are actually going in the wrong direction. So what are your thoughts about that?
Yeah, so I mean, just like anything, right? It's not very simple. I mean, the good news is that if you look at age standardized mortality for ischemic heart disease, it has gone down. Age standardized mortality from stroke has gone down as well. So that's the good news. If we look at overall age standardized mortality from hypertension, despite still very poor control, it has gone down. But then we have some issues where that has not happened. So if we look at the contribution of high fasting glucose, that has not gone down appreciably. If we look at obesity, the contribution that it has towards cardiovascular disease mortality has not gone down. And now we have a new player, which is ambient air pollution. The contribution of that towards cardiovascular disease-related mortality has gone up. So that's one piece of it, even in countries where there's progress. But now we've had about 30% reduction over the last 30 years in age-standardized mortality. But even when we look across the globe, that has not happened, right? So there are some countries where...
So it's not. So tell me about that. Are there regional patterns that we should be aware of, not just individual countries? It seems like it's regional patterns where we see differences. Can you give us some more insight?
Yeah. So I mean, the regions would be Sub-Saharan Africa, would be South Asia. If you look at Eastern Europe, these are the regions where we still have a lot of disease, and we have not had such a steep decline in cardiovascular disease mortality. Now, there are many reasons which could explain that. So yes, there's a lot of progress made actually, and we should definitely not count that out. But it has not been uniform, and I think that's where we need to be, because if we don't, then I think we talked about the projections up to 2050. These disparities will only worsen in the next 25 years if we don't do something about it.
Yeah, it's clear that this is not going to be enough, particularly for our population health goals, to just think about here or to just think about certain areas. We need to think globally. So that's very, very helpful. You mentioned the particular challenge, and we think a lot together about cardiometabolic health, that there's some particular challenges with regards to diabetes, hypertriglyceridemia. We see a lot of that, particularly in the South Asian area, and we see that even at not very high BMIs. That seems to represent a unique challenge. What do you think about that and the path forward?
Yeah, I mean, like in Pakistan, one of the highest rates of age standardized diabetes now, right, is where I spend most of my time every month. And we see it's not just prevalence, but early. Basically, these things are happening very early. So whether you look at diabetes, it's happening very early, almost 10, 15 years early. Heart disease is happening 10 to 20 years early. So the number of, years that you lose because of these comorbidities is also very high. So it's not just disease, but the disability that comes with that is very high. Now, do we know enough as to what's causing that? We probably don't. but it is probably, like anything else, multifactorial, right? So yes, insulin resistance in general is very high in South Asian populations, whether it's India, Pakistan, Nepal. I mean, you look at these countries, it's high. What's driving that? I don't think we fully know. It's probably a gene environment interaction kind of thing, where you have some genetic tendencies, but then you do need a second environmental hit. Now, that second environmental hit for a South Asian may be a BMI of 22, whereas for a Caucasian, it may be different. For an African American patient, might be different. But in these settings, it might be very different. And then there could be environmental challenges that are very, very unique to these countries, right? Whether that's diet, whether that's the way diet is treated. So I think that is where a lot of research needs to happen as well, as to what are those things that we should be measuring to actually identify somebody who's at a higher risk of diabetes or cardiometabolic abnormalities.
Yeah, so that's really helpful. And I think this actually leads into another theme that was a great focus of your talk, which is this idea of earlier detection, earlier intervention. And as you're describing, we're seeing a lot earlier disease in a lot of different populations, changes in mortality even in these younger populations. How does that translate here in terms of thinking about global health, this earlier being better for risk reduction?
Yeah, and American Heart Association and other societies have done a lot of work in case where we used to talk about secondary prevention, primary prevention. We're moving towards primordial, but then now the term is pre-primordial, right? So even when a woman is expecting, if she develops preeclampsia, gestational diabetes, we know this is going to be a problem in the child. And we showed some data that even in the first 10 years of life, if we look at it, these children show structural abnormalities in the heart. If mother had preeclampsia, or if the mother had gestational diabetes, they already show signs of obesity, waist circumference that's higher than other children where the mother did not have it. So I think it can be a challenge, but it's also an opportunity. What it means is that we can actually intervene early on. So the way I would look at it is, and that's what we showed, that over a lifespan, we need to see what are the places where we can intervene. So if a mother is coming for that antenatal care visit, what can we do, and look at it from that perspective, that if I'm treating that hypertension, picking that up now, or gestational diabetes, if I'm picking that up now, what does that do to the mother, which we have a lot of data on? What can I do with an eye towards the child who's not born yet? So as clinicians, if we start looking at it from that perspective, we communicate this risk to the mother. I think there's a lot that we can achieve. And perhaps there is an opportunity to screen the fathers as well, because some of them do show up, depending on which country and culture you're at. But at some point, you're going to find the fathers as well. And maybe that's the way to get into this early screening, especially for young men as well, which has always been a very big challenge. Not to say that we have not had screening challenges in the young women, but in young men, it's even more difficult in some of these countries to get them to come. But perhaps there's an opportunity to actually screen them and identify that risk, find out what's the best way to communicate that risk. And if treatment is needed, whether that's lifestyle or medical therapy, then we initiate it. And then having that eye towards the child as well.
Well, that's very helpful, and a really helpful framework just for thinking about, the need to get interventions to people earlier, identifying risk earlier. You started talking a little bit about treatment, and obviously we're in an era now where we have a lot of very interesting new tools in our armamentarium, whether we're talking about GLP-1s or SGLT2 inhibitors that have these multi-system benefits, but obviously those are not always accessible everywhere. And when we think about the basic therapies, kind of things that are now mostly generic and we know have a risk reduction effect, it sounds like even those we're not seeing being applied equitably around the globe. So what are your thoughts about that? And does that represent some low-hanging fruit for us to be able to use for actual population interventions?
No, great question. And again, this goes back to the two ways you treat disease when you look at a population level. One is you move the curve for a risk factor, blood pressure 1 or 2 millimeters, you push the entire curve a little bit to the left, but the entire population goes towards a lower risk pattern. Or you go to the very end of that distribution and pick highest of the high risk. And again, what we discussed during the presentation was that even when we look at patients with established cardiovascular disease, established ischemic heart disease, established ischemic stroke, if you look at the entire world, 20-30% of those patients are receiving 1 out of the 4 basic medications that you need there, right? Whether it's statin, antiplatelets, therapies for blood pressure lowering or beta blockers or RAS inhibition. So there's a lot of opportunity even to treat these highest of the high risk patients. And of course, there are challenges. These medications, as cheap as they might be in some parts of the world, and some of the low middle income countries, these medications still are very expensive. And that's where a question was also asked, that if you had to do a multi-developmental work, what would be the first thing you would address? Not an easy question to answer, but I do believe poverty alleviation is an important aspect. And that's why that discussion we had about having a multi-sectoral approach to these health. Health is just not something that happens on its own. It's something that happens in the life of a person, where poverty plays a role, where education plays a role, where social system and connectedness plays a role. So all of those things, if we can address them in a more holistic manner, we're probably going to be better.
So you're raising very profound questions with regards to how we can address this challenge in clinical environments, but also how we can address them, holistically from a societal standpoint. So just interested in your thoughts about what's needed to make these care models work. So in clinical environments, obviously, there's going to need to be some degree of thinking about the whole person and actually kind of overcoming barriers to get people in earlier and get earlier identification. But then what kind of care models are going to make sense just globally in these challenging environments to really actually move the needle here on global cardiovascular health?
So I think there are two ideas that come to mind. One would be that the current model of care is that patients have to come to the healthcare facilities. I think, can we take care into the communities, which has, of course, it is not a new concept. The concept has been there. But how can we basically find that model where we take care to the communities? Because most of the disease that's untreated is in the communities. Very small amount of that comes to the healthcare facilities. And a lot of times people are not even aware that they actually have a chronic disease. So that's one aspect of it. The second is that we can do everything we want in terms of identifying people with disease, but treatment will not happen till it's made affordable. And a lot of therapies that are therapies to treat common risk factors like hypertension, lipids, are perhaps not as expensive. But being expensive or not expensive is again a relative term. For someone living in US, it may not be expensive. Somebody living in South Asia or East Africa, it may be very expensive, right? So I think working with the governments, working with the civil society, working with the private sector to try to figure out what are those models that make these affordable for these individuals as well. I think those are the two things that come to mind.
Yeah, that's really very, very helpful and a great framework for us to consider. So now we are in the midst of a moment. We're seeing this opportunity, the challenges and the opportunity, as you described. As somebody who's, I would say, in the struggle, you're actively engaged in this work all around the world. Two different questions. What do we, as individuals who are interested in this, need to be thinking about doing better? And how can the AHA as well kind of get involved? Where are the next urgent steps to move the needle in cardiovascular health globally?
So, I mean, a lot of competing priorities, right? So that happens with every disease. Cardiovascular disease is no exception. And American Heart Association, for all the amazing work that American Heart Association does in terms of funding research, increasing awareness, advocacy, there's still a lot of work that needs to be done. Some ideas I have is that I think looking at cardiovascular health as something that's, we can work in our small domains, but understanding that if you're able to go across sectors, across developmental sectors, then I think we'll be able to realize gains that are going to be perhaps a little bit more than what we have traditionally done. So that's one aspect of it. And it doesn't mean that one has to go across all the sectors. Research now is not one person dependent. It's actually very collaborative compared to what it was 20, 30 years ago. So then having those teams where individuals have individual expertise, but then they are able to spread out and ask for assistance when it comes to poverty alleviation, access to care, how to use technology, how to use AI, if that is going to help us, right? Figuring out those models where we can tie all of these together versus trying to be a very purist and looking at one intervention on one disease condition with one way of doing it. I think there are perhaps very many ways of doing it. So that's one aspect of it. And I think for American Heart Association, for all the great work that's been done, I think just trying to maybe make our agenda more global, and a lot of work has been done, but I think with the tide now shifting more and more towards these countries in Asia and Africa and perhaps part of Eastern Europe, perhaps maybe taking a more global approach and considering what are ways to fund research to perhaps create more awareness in these regions. And a lot of that is happening, but perhaps maybe we need to think about if there is a way to double down on those efforts in the near future, so we
Well,
don't have those trends that have been there for the last 30 years continue for the next 25, 30 years.
well, I think it's an inspiring time with regards to the opportunities that are there. And it's always inspiring to have the chance to hear from you and speak with you. And I'm just really happy we had the chance to have that treat here at the American Heart Association Epidemiology Conference. So thanks to all of you for listening. And thank you again, Salim, for being here.
Thank you, Chiadi.